Chapter 15: Dr. Williams' Cancer Immunotherapy Pyramid and the Plan to Maximize Success.
I must stress that anything discussed in this chapter or elsewhere in this book should be discussed with your doctor before making changes on your own. It is important to know that what I've shared are general guidelines and they may not be suitable for all patients. Also keep in mind that our knowledge in cancer immunotherapy is growing at an incredible pace, so many new developments may occur. I will try my best to provide updates about new developments on our social media pages. In addition, the list of potential off-label medications and natural substances is exhaustive. It would be impossible for a cancer patient to take everything that has been shown to have anti-cancer properties. Many of these may have theoretical benefits based on laboratory studies, but it is still unknown if that will translate into anything worthwhile in actual patients. Some of these medications are popularized by stories of other patients' success, but keep in mind that each person is unique, so it may not transfer well patient to patient. These off-label medications and natural substances are also used in combinations that are not specifically studied, so the interaction and interference of responses generally are not known. In immunotherapy for cancer, we have to worry that certain medications might gain a patient's short-term success at the expense of a long-term cure. Below are suggestions for potential off-label medications and natural substances to enhance the anti-cancer immune response. The pyramid gives potential agents in different categories to enhance the immune response. This does not mean a person could or should take everything listed. Medications like Cialis and propranolol lower blood pressure, and some patients could not take either one, while many would not tolerate both together. I could not stress enough that unsupervised use of the listed medication and supplements can be dangerous, so always consult your doctor before using. Again, there are a limitless number of agents that could be on this list, but those that follow are ones that I feel have good scientific data.
Conclusion:
When I set out to join the legions of men and women who have been working for decades towards a cure for cancer, I knew the ride would be a long one. But I was unprepared for how rapidly advances in our scientific knowledge would speed my journey and bring me to where we are today, where a cure for cancer seems imminent. But the task remains a challenging one. Not only are the types of cancer complex and diverse, but so, too, will be their treatments. And even more diverse are the patients we treat. One thing I have learned to appreciate in my practice is that there are numerous factors that can affect a patient's immune response, from their own unique physiology to their mental state and the social support that they have to help them through their treatment and recovery. Almost all cancer patients feel overwhelming anxiety, stress, and depression, all of which can impact their immune response. High levels of stress stimulate the production of many hormones and neurotransmitters that reach the tumor microenvironment, as well as activate adrenergic receptors, which can promote tumor progression. At the same time, stress negatively impacts immune cell functioning, making it all the more difficult for the body to fight cancer. For example, in a paper published by Eng et al., researchers reported that tumors could contain adrenergic receptors, which are associated with increased tumor aggression. Their study also shows that one common biological response to stress is the release of norepinephrine, which is responsible for inhibiting the anti-cancer immune response, while various immune cells, such as Tregs, a type of T cell first discussed in Chapter 2 that helps prevent autoimmune disorders, MDSCs, myeloid-derived suppressor cells, and TAMs, tumor-associated macrophages, may be affected as well, further reducing the immune response. In Eng et al. Study, mice that were kept at a cooler room temperature, which causes chronic stress, had their tumors grow at a faster rate as compared to the mice kept at a warmer, more comfortable temperature. This finding suggests that minimizing chronic stress can have a powerful beneficial effect on the immune response. Yet minimizing chronic stress in cancer patients is no easy task. Not only is the cancer diagnosis itself profoundly stressful, but so, too, is the treatment. One area being studied is the effect of chemotherapy treatment on the immune response. There is some evidence that chemotherapy can enhance the immune response. However, there is also concern that it may hurt the immune response. This raises the question, should immunotherapy be used before chemotherapy? I think that we will have a better idea of this answer in the next few years, but in the meantime, many people are questioning whether prior chemotherapy treatment is hurting the potential for success with immunotherapy treatment. At the moment, it seems certain types of chemotherapy may hurt future success of immunotherapy while others may help it. The book Yoni Kasari has edited, Tumor Ablation, Effects on Systemic and Local Anti-Tumor Immunity and on Other Tumor Microenvironment Interactions, has a very good chapter on this subject. Eng et al. Also cited studies that have shown that stress from surgery results in immune suppression, which inhibits the anti-cancer immune response, increasing the chance of recurrence. Consequently, it is critically important that any treatment plan includes stress reduction as a fundamental component of therapy. Toward that end, I found in my practice that many patients have success with meditation, which helps control the mind and relax the body, and yoga, which works in much the same way as meditation. Having a strong support system is also important, and I encourage my patients' families to be engaged in the treatment plan and understand that they play a vital role in the recovery process. The impact of surgery on stress levels is another reason that less invasive procedures such as cryoablation may be a good alternative to conventional surgery when possible. However, when surgery is necessary, it may be possible to counteract some of these effects with beta blockers, such as the drug propranolol, which inhibits beta-adrenergic receptors and thereby helps block stress-induced tumor progression. Clinical studies have indicated that cancer patients using beta blockers to treat their high blood pressure have improved survival independent from other treatments. One huge advantage is that beta blockers are already available and can be used off-label. As these studies and findings show, the immune response and the cancer's ability to evade the immune system create a complex interplay shaped by the many different factors. Not only are there different types of cancer, but each cancer can be unique to that patient, with a different immune response irrespective of the cancer type. Also, the same tumor type can have a different immune response based on the tissue it grows in, adding to more complexity. One thing that is quickly coming of age is our ability to monitor hundreds of immune-related substances in the blood. These advances can allow us to monitor the immune response generated in individual patients and alter therapies accordingly based on each patient's unique immune response. This certainly will lead to a true personalized medicine and improved treatment outcomes. One of the most exciting developments in this regard is in the computerized data analysis. One such program, IBM's Watson, has been able to read all the studies and findings in cancer research and make recommendations of treatment options based on the patient's unique biological profile. While access to this computer remains limited, other computerized diagnostic tools are increasingly used by oncologists and other doctors to develop unique treatment profiles. Moreover, because the immune response is so dynamic, continuous monitoring of these immune factors will allow us to adjust treatment and monitor response on the fly, instead of waiting for outcomes on the scans, which can be months down the road. As I reflect on the successes we've had and on the possibilities before us, I am struck by how rapidly our understanding of cancer and immunotherapy is evolving. There now seems to be an almost limitless number of immune agents being developed, and as a result, we probably already have a sufficient number of immune agents to cure the majority of cancer patients. And while this vast array of agents add to the difficulty in fitting the right agent to the right cancer in the right patient, we aren't looking for a single immune agent. Just as we have seen in the treatment of HIV and AIDS, combinations of drugs will be essential to effectively treat cancer, based On our ongoing work in cancer immunotherapy, we now know that autoimmunity increases when a combination of different agents is used. Moreover, by injecting the agents directly into the tumor, we can help reduce autoimmunity, which makes it easier for the patient to be able to tolerate the combinations needed to have a successful cancer treatment. This is not as possible when given by an IV, flooding the entire body. Some of the necessary drugs like TLR agonists can only be injected into tumors or used topically due to the toxic immune response if used systemically. At this moment, everything in the future of cancer immunotherapy is pointing to having at least some component of intratumoral therapy. This knowledge, combined with the growing number of immune agents, allows for a higher number of combinations of immunotherapies without flooding the body with any one single drug, theoretically reducing the risk of side effects, including autoimmunity. In conventional cancer treatment, the drugs are delivered to the entire body, which can cause debilitating side effects and prove to be more than the patient can tolerate. But by delivering those drugs directly to the tumor, the body is spared the massive dosage of drugs, which instead are focused exclusively on the tumor. Moreover, by directing the drugs to the tumor itself, not only is a lower quantity of the drugs needed, the cost of those drugs is reduced as well. As I write these closing lines, I'm encouraged to know that numerous other immune checkpoint agents are close to approval. Among the ones I suspect we will soon see are TIM3 and LAG3, which are classified as co-inhibitory receptor targets and are similar to PD-1 and CTLA-4. But unlike those receptors, TIM3 and LAG3 have specialized functions and tissue sites. Another promising area of research is the addition of toll-like receptor agonists, TLR, with immune checkpoint inhibitors. TLR agonists are a class of proteins that play a key role in the immune system, and when they are directly injected into the tumor, they help activate an immune response that can ultimately translate to a specific and long-term immunity. Though TLR is a medication that has been around for years, its use has been limited to a topical cream used to treat genital warts, keratosis, and basal cell carcinoma. Given new research into the role TLRs play in cancer immunotherapy, however, we are already performing treatments that include injecting TLR agonists CpG, imiquimod, risankizumab, and gardatumumab directly injected into the tumor, combined with cryoablation and immune checkpoint inhibitors. Thus far, the results are extremely promising. Also, as mentioned, one of the extremely promising areas of treatment is the injection of an OX40 agonist antibody with a TLR agonist, like in the Stanford cancer vaccine study published by Levy. We are already working with human patients in the same area as well. I have found in my work that focusing on the tumor microenvironment is the key to combating cancer. By teaching the immune system to attack the tumor directly, the immune system will go on to attack the cancer in other locations, while not triggering the immune system where no cancer is present. This treatment strategy generates a systemic immune response, also known as abscopal effect. AB is Latin for away, and scopus is Latin for target, and thus the abscopal effect refers to effects that extend beyond the targeted area. Because of this abscopal effect, it is not necessary to target every tumor in the body to obtain a good response. If there is a cancer elsewhere in the body, the immune response can detect it, while the right combination of immunotherapy agents can maximize the anti-cancer response while keeping the immune system from attacking the healthy elements of the body to the lowest possible. This is very important in advanced cancer cases, where it would be almost impossible to target every tumor in the body. This direct intratumoral injection of immunotherapy is my main area of work and is receiving a lot of attention by medical scientists, which is a profound change in cancer care because it shifts the treatment from oncologists to radiologists. As I've said previously, because oncologists are not trained to perform these procedures and radiologists are, oncologists remain hesitant to refer their patients to radiologists for effective treatment. We therefore need to follow the radical shift in our understanding of cancer treatment to a radical shift in our paradigm of cancer treatment. As oncologists learn to work alongside radiologists, and as radiologists begin to play a more prominent role in cancer treatment, we will completely shake up the cancer world. This is well overdue. When I began performing ablation on patients in 2002, I started by focusing on breast masses where the cancer had already spread. I was also doing ablations in other parts of the body that were not considered standard at the time, such as bone, lymph nodes, pelvic masses, and adrenal glands. But just as with surgery, we could not get all of the cancer, and even if we did, the cancer would usually come back. That is the nature of cancer. There is usually much more cancer in the body than is visible in the scans. It is hiding as microscopic disease, waiting to strike again. That has been the problem with all cancer treatments. Rarely can all the cancer be eliminated. But with immunotherapy injected into the tumor with or without cryoablation, that problem is no longer insurmountable. By the end of 2014, with the approval of PD-1 inhibitors Opdivo and Keytruda, we found the key that we'd been missing. That was when we began to see a vaccine-like response, not in 1 out of every 300 cases as we've seen with ablation alone, but in a larger number of our patients. The PD-1 inhibitors had opened a door that enabled other agents, once ineffective when used alone, to become far more effective. While the PD-1 inhibitors are not the complete answer and we have a long way to go, they did result in the biggest improvement in patient response that, in my view, we have ever seen before in the history of any cancer treatment, at least up till now. I would argue that while new agents are being developed on a nearly daily basis, the agents already exist to make cryoablation combined with immunotherapy an effective cure for cancer in many solid cancers. We've achieved this result with mice, but curing mice is rather easy business. Curing humans is what we are after. But the human immune system is far more complex than that for a mouse, which creates added difficulties in treating cancer. In my own practice, I have developed a combination of approved immune agents, ablation vacs, which I inject into the ablated tumor. The results have been impressive, but we must still refine the procedure if we are going to get that goal of over 90% success rate. Toward that end, we are studying other agents that have not yet been approved, and I think we are close to reaching our goal. But in order to do so, we need to get these treatments to patients as quickly as possible because time is ticking and people are losing their lives. Unfortunately, waiting for FDA approval for new but effective agents can take years. In the past few years, there have been some major discoveries, but it is frustrating to know that it could take 10 to 15 years for some of these agents to be approved. Dr. Tetsuko Honjo of Kyoto University first discovered the immune checkpoint inhibitor PD-1 in 1992, but it wasn't until 2014 that Keytruda, the first PD-1 inhibitor, was approved. While I feel it is critical that we know that the drugs we are using are safe and effective, I can't help but wonder how many people would still be alive today if that drug had come out 5 years sooner. Moreover, even when Keytruda was approved, it was approved for melanoma only. Not only did that mean insurance would only cover it for melanoma, it also meant that if a person had another cancer, such as lung or kidney cancer, and asked for their doctor for the PD-1 inhibitors, they would inevitably be told, "Oh, that doesn't work for your type of cancer." But approval and effectiveness are not necessarily the same thing. How many patients missed their opportunity to be cured? Or at least had their lives extended by years? Because their doctor would not step out of the box and offer them immunotherapy? It is no different with cryoablation and immunotherapy. Patients are typically offered single-agent immunotherapy or cryoablation in place of immunotherapy. But by combining multiple agents with cryoablation, we can save tens of thousands, perhaps even hundreds or thousands of lives each year. Unfortunately, most doctors want to wait for more studies to prove this treatment strategy will work. ignoring the empirical evidence that already exists demonstrating that this is the way to go. I am confident that the combined treatment of cryoablation with multiple agent immunotherapy will eventually become accepted as the standard of care. Yet, as I recall watching my grandmother suffer when I was a young teenager, I remember wondering if there was something out there that could help her. Something maybe even right under our noses that we just didn't know about. I don't know if it was true back then, but I sure know that it is true now. Although we can use all approved agents off-label in the US, regulation at individual hospitals and insurance limitations have made it virtually impossible to perform our work in the United States. Consequently, my team and I are taking our work outside the US to help speed up this access to new agents for our patients. We have a thriving practice in Mexico City, Mexico, but we intend to continue our work in the United States. We currently have an office in Atlanta, Georgia. I hope that this book has been helpful and has given you some guidance in your cancer care. If you are a doctor who treats cancer patients, I hope I have provided you with enough information to continue researching the topic so that you can better treat and refer your patients. If you are a cancer patient and being treated with immunotherapy, you certainly need to consider the things that can help improve your chance of success, including Bifido-Breve and Longum, and NSAIDs such as Celebrex or aspirin. Clearly, if cryoablation is an option for you, I hope that you will strongly consider that. Cryoablation functions like an immunotherapy on its own, and as you know by now, immunotherapy injected into the tumor at the same time seems to increase the success rate many times more than either on their own. The whole is much greater than the sum of its parts when it comes to combining cryoablation with multiple agent immunotherapy. I do hope that the information you have gained in this book will help you succeed in your battle. I would like to think that my grandmother is looking down and smiling, knowing that her death was not in vain. I am confident that the pieces to the puzzling cure for cancer that we have been searching for are right here, right under our noses. This puzzle is quickly coming together, and if you have cancer, your chances for a healthy future have never been greater. I wish you great success!